Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for April 17th, 2024. Thank you for joining us this month. Our presenter today is Stephanie Rosado. Stephanie is a PhD in the School of Social Work at the University of South Florida, a Research and Evaluation Associate at the Foundation for a Healthy St. Petersburg, and a certified wellness and health coach. From her career as a professional athlete to her experience as a licensed social work supervisor in an inner-city child welfare agency, Stephanie brings a wealth of unique expertise and skills that inform her work in the realms of social work, research, advocacy, and overall wellness. As an arthritis warrior herself, Stephanie uses her own experience with osteoarthritis to align passion with purpose. For example, she serves as a volunteer for the Arthritis Foundation at local and national events, the most recent being the 2023 Pathways Conference, where she was invited to be a part of a panel of patient voices, subject matter experts, and scientists to discuss clinical trials and the future of innovative treatments for osteoarthritis. Overall, Stephanie is passionate about promoting positive health, mental health, and lifestyle outcomes for various populations, including minoritized racial and ethnic groups, athletes, and adults. Her research has focused on health and well-being, sports social work, and her dissertation research specifically explored social role participation, identity, and satisfaction with life among adults diagnosed with osteoarthritis. The title of today's presentation is Using the Social Identity Model of Identity Change to Explore Social Role Participation and Identity Among U.S. Adults with Osteoarthritis. Welcome, Dr. Stephanie Rosado.
Thank you for that lovely introduction, and thank you for having me. Thank you to the Osteoarthritis Action Alliance for this opportunity to disseminate my work. As Katie alluded to, this presentation will be based off my dissertation study. So with that, we'll get started. First, I just will lay out a quick agenda of what you can expect for today's presentation. Feel free to scan this QR code. In the meantime, this will link to a handout. And also the link to the handout will be put in the chat for those of you that cannot scan the QR code at this time. I'll go over a brief lit review, talk about the purpose for all you researchers out there. I'll talk about the analytic plan and methodology for this study, results, and then discussion and implications. And I'll leave about 5 minutes or so for Q&A. Please use the handout to facilitate this presentation, as I will skim over and brief over a lot of information in order to save that time for a Q&A. So first, many of you on this Zoom call may know the difference between arthritis and osteoarthritis. However, I think it's important and imperative to always hit this home and talk about this distinction, because I think it leads to a lot of misconception, misunderstanding in the arthritis and patient community sometimes. So arthritis is a big, broad umbrella term of over 100 types of arthritic chronic diseases. And osteoarthritis, on the other hand, is very specific. It's under that umbrella term, but it's talking about that cartilage breakdown within the joints that leads to physiological changes of the bone and joint structure that ultimately results in physical limitations of the joint. It can affect any joints. However, it's most common in the knees and hip. And then I'll briefly talk about some prevalence, risk factors, and outcomes. I won't go over this whole slide, but I'll hit the highlights. 1 in 4 adults have some form of arthritis, and OA is the most common type. And it's the leading cause of work disability, not just here in the US, but worldwide. So this really sets the tone for this study and demonstrates the importance of a study like this. Some risk factors are being overweight, injury, repetitive motion that leads to injury, and physically demanding occupations. Some key points from the lit review. There really has been, if you look at the literature over time, there's been this shift in frameworks and ideology in the literature from a more medical model that focuses on how do we measure OA clinically, right? Like, how do we measure this cartilage cartilage loss, and things of that nature to a more holistic and integrated care approach. Because over the past few decades, we have grown this acknowledgement and knowledge that OA indeed affects other areas of life. This growing body of literature also highlights that the combined effect of OA and other social determinants of health contribute to outcomes in other well-being areas. OA has been associated with depression, anxiety, shame. Qualitative research has described this mourning process associated with OA. So, reviewing the literature, there still are some gaps and some holes that researchers need to fill in. For example, how OA impacts social role participation, change in identity, and satisfaction overall. Jigneck and colleagues have explored this a little bit, but there's still so much unknown about this area. Additionally, middle-aged and younger adults are understudied as well. However, my study that was published last year talked about younger adults and explored younger adult experiences with OA, and they too are struggling with some of these psychosocial outcomes of having osteoarthritis. So the purpose of my study was to explore factors contributing to social role identity as it relates to satisfaction with life in adults who have OA. And in order to do this, I identified a model to sort of ground this work. And the social identity model of identity change was originally constructed to better capture life transitions like retirement. And this model basically says that belonging to multiple groups or identifying with multiple groups, this is something that people do naturally and people have before going through a life change or transition. Once that life change or transition occurs, people either gain new identities, they maintain identities or group memberships, and they can even lose some of them. And ultimately, this affects adjustment and well-being. I wasn't able to find any studies that use this model for OA specifically. Other applications were multiple sclerosis, substance abuse, aging studies, and so on. So there was a need to adapt this model. And I needed to adapt it in order to narrow the scope of the model to better study the target population, adults with OA, and also to better interpret the model's suitability for understanding the effects of identity and social role identity transitions on well-being. So aside from operationalizing belonging to multiple groups as role salience or identity, and operationalizing adjustment and well-being as satisfaction with life, I adapted this model in two primary ways. One way was right after the life change or transition, which in this case is diagnosis with OA, to include post-diagnostic factors that are well represented in the literature, such as role limitations, expectations of having OA, and disease knowledge or awareness. The other area where I adapted this model was right in between those identity pathways and that adjustment and well-being or satisfaction variable. And this really is an expansion of what we know about theoretically this relationship between identity and satisfaction with life. And it proposes that there is a moderation here in between that relationship, that satisfaction with role performance may moderate the relationship between identity and satisfaction with life, and social support may also moderate that effect. So we go from this SIMIC model to now an adapted SIMIC model for osteoarthritis. So going into the analytic plan and methodology, how I actually conducted this study, I conducted this study via a cross-sectional survey using Research Match across a crowdsourcing online platform for medical research. And three primary research questions were based off the SIMIC model that I just presented for OA. And I needed about 153 individuals to participate in this survey in order to continue with my analysis and analyze my research questions. This research study was IRB approved through the University of South Florida IRB, and these ethical considerations were taken into account, along with providing incentives for individuals, pre-testing, and also feasibility testing of the survey. The criteria to participate in this study, you essentially had to be an adult diagnosed with OA, and you couldn't have another arthritic or chronic condition that impaired joint function. So let's get into the research questions. Again, the research questions are informed and represent and coincide with each segment of the SIMIC model for OA. The first question asks, to what extent are post-diagnosis factors associated with changes in self-reported identity? And this was analyzed using a hierarchical linear regression. Research question 2 asks, to what extent is the change in self-reported identity associated with satisfaction with life? And research question 3 as to what extent do social support and satisfaction with role performance affect that association between identity and satisfaction with life. And the second research question I forgot to mention was analyzed via multiple linear regression, and the third was a moderated moderation analysis. These are my control variables. And I use these control variables in each and every research question: age, amount of time living with OA, sex, race, education, and depression or anxiety. I don't know if I mentioned this when I mentioned the handout earlier, but these page numbers with the red circle around it indicate the page number for the handout related to this information presented on the slide. The next 3 slides are very busy, but I will just brief over them and summarize them. This is really for my researchers in the room who want to know how these variables were operationalized and what specific measures were used to operationalize each variable. So you can find more information about the original creators of the scale and just more information from the literature about each scale in the handout. So please refer to it. Essentially, this lays out my independent and dependent variables for each of the research questions, and it provides a sample item. For research question 2, independent variable, change in identity, dependent variable, satisfaction with life. And then that moderated moderation with the primary and secondary moderator being satisfaction with role performance and social support, and how they were measured in this study. I'll talk about some internal consistency that resulted from this study because it's important for future research to recognize, and it's important before we go into the interpretation of the results. All the scales utilized in this study to operationalize the variables had strong, good, or acceptable evidence for reliability or internal consistency, with the exception of the patient knowledge questionnaire for OA. However, because knowledge of OA is a complex construct, achieving a high level of reliability may be more challenging. This may be the reason that it's the only measure that I could find from available literature for this construct. It's an area that needs further development and exploration. And also, I decided to continue on using this scale because it was the only one that I could find. There is no gold standard for patient knowledge. And also, I didn't want to risk removing any items from the scale that could have been problematic because I did not want to risk losing important information when this is not a clear construct to measure. So keep that in mind as we interpret the results. Some sample characteristics. I ended up with a sample of 193 US adults with osteoarthritis. My sample was primarily white and female, 74% white, 76% female. They were mean age 56 years old, which is actually pretty young in comparison to what's available in the literature on osteoarthritis. This sample was highly educated. Most of the sample had at least a bachelor's degree, 33.7%. Master's and doctoral degree holders were 37% of the sample. Married, no children, and most commonly reported having OA in the knee, hands, and or spine. More sample characteristics and more details can be found on page 10 of the handout. So let's get into the results of each research question. For the hierarchical linear regression, research question 1, this table really just represents each model of the hierarchical linear regression. The first model included all of the control variables, and then each additional variable or predictor was added in the next model. So the control variables were statistically significant and accounted for 8.3% of the variance. When I added knowledge of OA, it was not statistically significant. And then when I added positive and negative expectations in the third model, it was not statistically significant. However, the fourth model, which included role limitations, was statistically significant and accounted for 26.2% of the variance in changes in self-reported identity. And so this is the more detailed view of model 4, and this model suggests a negative relationship. For every 1 unit increase in role limitations, there was a corresponding decrease of 0.44 units in the change in identity, holding all other variables constant. This basically means that the more someone experienced role limitations, the more likely they were to experience a decrease in that identity role salience variable, the less they identified with certain roles. Research question 2, to what extent is the change in self-reported identity associated with satisfaction with life? The combination of all variables accounted for in this multiple linear regression accounted for 22% of the variance in satisfaction with life. And there was a positive relationship between change in identity and satisfaction with life, meaning that the more that someone was able to identify with their role, right, an increase in change in identity, it was associated with greater satisfaction with life. So that also kind of coincides with what the SIMIC model proposed. And then that last research question, that moderated moderation, post-OA identity was the focal predictor, satisfaction with role performance was the primary moderator, social support, or Z was the secondary moderator, and satisfaction with life was the outcome variable. And what's important to understand with this conceptual diagram, which really represents the research question, is that the secondary moderator is not expected to influence the relationship between X and Y, but the secondary moderator determines when the primary moderator, satisfaction with role performance, will have an expected moderating effect, altering the strength or direction of the relationship between identity and satisfaction with life. That diagram on the right really allows us to interpret the results, so I'll zoom into that. And what we see here is that the interaction effects were not statistically significant. That moderation effect was not statistically significant, but even though the interaction terms were not statistically significant, it doesn't necessarily mean that there are no subgroups for which the interaction may be statistically significant. And the absence of these statistically significant findings does not imply that the interaction does not have any meaningful theoretical contributions. So I decided to probe these interactions further and look at the conditional effects of the focal predictors at values of these moderators. And what this basically means is that this column here represents satisfaction with role performance at low levels, average levels, and high levels in social support at low levels, average levels, and high levels. So if we want to interpret what this is saying, it's saying that at high levels of satisfaction with role performance and lower average levels of social support, we did see those statistically significant interactions for those moderators. So not to overstate these findings, the overall model was not statistically significant. However, this lends itself to something future research should consider, because it's showing us that maybe in certain subgroups, this moderation may exist. So just to summarize those results really quickly, Research question 1 showed us that an increase in role limitations is associated with a decrease in role salience identity. The more someone struggles with OA-related role limitations, they may identify less with those social roles. Research question 2 showed us that positive identity gain, identifying with other social roles, is associated with increased life satisfaction. And then that moderated moderation, research question 3, showed us that the conditional effects suggest that the interaction may exist at high levels of satisfaction with role performance and lower average social support. No study is without limitations, so I will just briefly mention the limitations apparent in this study. It was a cross-sectional design. Individuals were asked for information at one point in time, and it did not follow them across time. Crowdsourcing limited the sample diversity, primarily white and female sample, so that's a limitation. There was some missing data. This study asked participants to retrospect on social roles that they had prior to being diagnosed with OA, and also methodological limitations of survey and instruments. For example, I already mentioned the OA knowledge construct and limited evidence for reliability with this scale. So moving into some discussion and implications of this work, first, related to the SIMIC model for OA that was proposed. The first part of the model lends itself to implementation and practice. While previous research has focused on cognitive factors such as patient knowledge and expectations, this study really emphasizes and highlights the critical role of functional limitations of OA in explaining variations in role salience and identity changes. The primary and secondary moderators proposed in the third research question lended itself more to theory expansion. So although the results were not statistically significant, the closer look at the conditional effects of the moderators show that perhaps the proposed SIMIC model may need further refinement, further exploration, perhaps with a broader sample of US adults with OA. This study has relevance for social work. The NASW standards for social work practice and healthcare settings talks about knowledge in standard number 3. And social workers are experts at linking physical and mental health and understanding that overall experience. OA is the leading cause of work disability worldwide. This means that clinical training, classes on OA, musculoskeletal health, internship opportunities to work in musculoskeletal health and case management settings with this population is imperative for the social work profession and education to consider. I can only speak from my experience and my clinical training and my institution, and I didn't have that exposure. We didn't talk about musculoskeletal health. We talked a lot about a lot of other chronic health conditions, but this is an opportunity for social work. Also, the third standard highlights knowledgeable of current theory and evidence-informed practice. Social workers' strength-based perspective can be leveraged in the understanding of theories and practice implications outside of the traditional social work roles in order to improve outcomes. For example, applying what we learned from this theoretically grounded study, social work may translate social role limitations into a strength-based social role abilities. This could serve as a crucial mindset shift for OA patients receiving services from social work professionals, since the SIMIC suggests that maintenance and gaining of new identities are contributors to wellness. And lastly, this standard also highlights social work's role in research and evaluation methods. This just means that social workers must be critical consumers of research and hone in on their ability to analyze research findings even outside of traditional settings, to improve services and advance the profession overall, which is a perfect segue to talk about the relevance for interdisciplinary teams. Although social role participation and identity are not traditionally addressed by orthopedic or musculoskeletal physicians, whether that be because it's outside of their scope or they don't feel comfortable talking about those things with patients, the research shows that this is a frustration for patients and providers alike. So these areas are well aligned to suit the scope of the social work profession. Social workers are experts in guiding individuals and families through life's transitions and challenges, and osteoarthritis is a public health concern. It is not an exception to the benefits they can provide. Social workers can really help bridge this gap in interdisciplinary care for OA. This slide really embodies what I just highlighted about social work and interdisciplinary teams. So I'll just read it aloud. The word function might imply motion and grip strength to a hand surgeon, a time Jepson test to a hand therapist, and ability to accomplish daily tasks for a psychologist or social worker. This is the value that social work can bring to interdisciplinary teams. And so it should be explored further and capitalized on. And then relevance for patients. This study has a lot of key points for patients to consider. And I would encourage patients to ask themselves, what social roles does OA affect in your life? Are there alternative social roles that can help navigate emotions associated with loss of another social role? Have you talked to anyone about how you're coping with OA role limitations? And I would encourage patients to advocate for themselves at office visits, within relationships, families, etc. Find social support, community, resources to help you during identity shifts. Some of the resources I've highlighted here, the Osteoarthritis Action Alliance and the Arthritis Foundation, both have support mechanisms and resources in place to help patients in these transitions. I know I'm running a little bit short on time, so I'll just wrap up here with future research and what is needed from future research. Longitudinal studies of adapted SIMIC model for OA, validation of the social role participation questionnaire for US populations, defining that construct. What is knowledge of OA? What do patients need to know? And is it dependent on the patient, what they may need to know versus another patient? Assess social work education, internship, and training for opportunities to test evidence-based practices, interventions that promote well-being for various adult populations or any population with OA. And then highlighting and exploring this invisible illness. OA is already an invisible illness. You can't see someone and know they have OA, but within that, there are invisible and marginalized populations. Homeless individuals with OA. Women take on both paid and unpaid labor as breadwinners and homemakers, an invisible marginalized population that may be predisposed to OA. So just looking at these specific populations further. I'd like to acknowledge my funders for this study and also my committee members at the University of South Florida. And with that, if we have time to take more questions, I would be happy to do so.
Thank you so much for that presentation, Stephanie. To my knowledge, we haven't featured social role or identity as a topic in previous Lunch and Learns, or even for that matter, a lot of topics relevant for social work. So, and it sounds like you discovered in your research there really isn't much work that has been done in that area. So we're very grateful to add your expertise on the topic to the OA Action Alliance resources. And we do have a couple of minutes for questions. So if you have a question for Stephanie, please feel free to type them in the chat. One question I had that I was just interested about, as you talked about social roles and not being super familiar with them myself, wondered kind of which social roles did the study account for? And did you find any interesting themes or patterns in role loss or role identity?
Yeah, thank you. That's a great question. So the social role participation questionnaire by Jignac and colleagues, it accounted for physical leisure, hobbies, community and cultural involvement, socializing, casual contact with others, travel, working or employment, education, close and intimate relationships, children, stepchildren, or grandchildren, other family, and just a global question about overall how satisfied individuals were with their social roles. I didn't look at, this study was not focused on looking at each individual role specifically. However, in disseminating my work previously, someone brought up a very good point. It was actually Dr. Jason Kim from the Arthritis Foundation, and he said something about like, what about volunteering as a role, and could that have a implication for identity, right? Like someone who has perhaps been diagnosed, like myself, with OA, and then chooses to work in that field or volunteer in that field, and could that then that identity gain give them some sort of additional satisfaction with life or improved wellness, right? Because they're also doing work in that area. So that was something interesting that I found and that came out of this study.
That's a good point. And even getting involved with research, I know that
Mm-hmm.
some people may feel like they're giving back to future generations, and certainly potentially, to researchers who may develop interventions or discover interventions that can be used in their lifetime. That's a good point.
Right. That's how I got into
Mhm.
it.
Yeah, thank you. We do have a question here in the chat, which I think will make our last question. Are you aware of resources that offer complementary services with social workers for those diagnosed with OA to better navigate their new identity journey? It's a great question.
Ooh, that's a great question. And no, I don't know a specific resource that's geared towards like social work and musculoskeletal health specifically, but there are organizations that kind of capitalize on this mental and social health aspect. For example, the International Musculoskeletal Mental and Social Health Consortium, or I think it's i-mesh.org, is one organization that's dedicated to sort of this bridge between musculoskeletal health and overall well-being, including mental health. And there's social workers and social work researchers a part of that group. However, a dedicated group, no, but sounds like a future opportunity that I need to need to explore.
Excellent. Yes, definitely. Maybe some room for potential partnership in the future on getting that together.
Yeah, for sure.
Well, thank you, Stephanie, and for that presentation, and thank you to everyone who attended today's Lunch and Learn. In just a moment, we'll launch a brief poll. If you can take that before you leave, we would appreciate it. And finally, I'll announce our May Lunch and Learn information. We're going to host 2 Lunch and Learns in honor of Arthritis Awareness Month for May. Each presentation will highlight one of the 2 newly recognized arthritis-appropriate evidence-based programs from the OAAA Action Alliance review process. So on May 15th, we'll have Eva Roos, who will present on the Good Life with Arthritis Denmark program. And on May 29th, Rachel Nelligan will present on the My Knee Exercise program. Links to registration for those events will be included with the email of today's presentation recording. Thank you again for attending, and I hope everyone has a great rest of your day.
Thank you.